Well, thank you for coming. My name is Paul Demeda, and I am happy to be here today to talk about high cholesterol prevention and treatment. It's one of my favorite topics because it involves controversy. That is what makes me go, because I'm always learning. When I see stuff that's controversial, I got to look into it, and that causes me to learn stuff and develop a better picture of the way things are going. It seems our whole world and medical industry is full of controversy. So is the nutrition side. So I'm happy to be what's called an orthomolecular medicine practitioner. Orthomolecular medicine is basically you look at a person, you figure out what the right dose of the right nutrient, the right reason, and the right time is for that person. So it's very individualized. So you cannot go in and sit down with somebody for 2 or 3 minutes and figure out what to do with them. You have to really know that person basically from the ground up. So that requires a lot of getting to know the person, but also understanding how things work, like how the body works, how the anatomy, physiology, and the biochemistry work, and also how nutrients work. And that's part of what I learned at this school, was how nutrients work and the roles in the body, how the body works, and all that kind of stuff. So with this talk, we're going to bring all that stuff together, and I'm going to talk about this high cholesterol and prevention and treatment. And the controversy is we should not be treating cholesterol at all. And I'm going to go through and explain why cholesterol is not the issue. So we kind of start like this. And so if you go to the Mayo Clinic and you look up heart disease, you're going to see lots of stuff there, lots and lots of stuff. But the definition here is of heart disease. I'm going to pull out a few quotes from there. Heart disease are conditions that affect your heart, blood vessels, coronary arteries, things like rhythm problems, heart defects, and all that kind of stuff. But heart disease is often used to describe cardiovascular disease. So when they mean cardiovascular disease, they're actually saying heart disease. And when they say cardiovascular disease, they're actually talking about atherosclerosis. So for the most part, when people are talking about heart disease, they're talking about atherosclerosis, or that buildup of plaque inside the arteries that can block blood flow to things like the heart or other parts of the body, or cause a rupture or something that will block blood flow later down the road. So if we go to the National Institute of Health, and these guys are the National Heart, Lung, and Blood Institute together, and you go to their page and it says, how does cholesterol cause heart disease? So cholesterol causes heart disease, and it says too much cholesterol builds up in the walls of the arteries, and over time it hardens up, and the arteries become narrow, and then the blood flow is either slowed down or blocked. And this is actually untrue. And it's kind of true, but it's untrue technically speaking. And we'll see why as we go through this. In order to understand what the role of cholesterol is in all of this, we have to understand what cholesterol is. And cholesterol is a simple molecule. It's actually not a simple molecule, it's a complex molecule, but it looks like that. And there's a whole bunch of carbons, and there's a couple of hydrogens and oxygens and things like that. And the body actually uses it. It's widespread in nature, and it has been and always has been part of human diet and part of human anatomy and physiology and biochemistry. So that's the molecule, and so this molecule has many roles in the body that are actually very important. So let's run through them. First one, probably the most important one, is cell membrane integrity. So every cell has a wrapper around it, and it keeps the outside out and the inside in, but it's way more than that. The wrapper is actually the brain of the cell, because there are receptors and proteins in there that read the external environment, the outside of the cell, and they pass a message through to the inside of the cell and say, this is what's going on, this is what you need to do. So when the outside of the cell perceives its environment, like the brain perceives its environment, messaging goes in to the nucleus, and the nucleus is the core of the cell, and what happens in response is we write proteins to basically run the function of the cells. So that wrapper is really important. This is what it looks like. This is from the, if you guys are going to take anatomy here, this will be the anatomy textbook picture of the cell membrane. This is the outside of the cell, and this is the inside of the cell. Water-based outside, water-based inside, but the cell membrane itself is fat-based. it's about 60% fat. And so 60% of the wrapper around the cell is fat. And I don't know if you notice these little orange guys. They look like these guys. And that's cholesterol. And cholesterol is built in there for a few reasons. And one of them is to provide that cell membrane integrity. So it makes the cell membrane more flexible, but less permeable. And why would we want to do that? There are times when we'll be exposed to toxins, and so toxins in the environment or from other places that we don't want inside our cells, because toxins poison cells. And so we want to put or decrease the integrity there, and so we build up the barrier. There are times when people will be dehydrated, especially long-term chronic dehydration. We do not want to leak the water out of our cells, because the inside of a cell is basically water-based, and the less water in it, the more gel-like it becomes. The more gel-like it becomes, the less or the more difficult it is to move things around inside, and so the cells behave less and less efficiently. So that's it. So the next role of cholesterol is that it's a component of bile. Now, bile is a fat emulsifier. So one end of it kind of attracts water, and the other end kind of attracts fat. And what that does is it helps pull big fat globules out of our digestive tract, breaks them down so the enzymes that digest fat can break them down more efficiently. So we put cholesterol into bile to help serve that process. So cholesterol is important there. Cholesterol is also a precursor to steroid hormones, and steroid hormones are the ones that are made from cholesterol. There's a whole range of them, and this is the kind of the breakdown flow chart of the steroid hormones, or the key ones. And if you look at it, we start here with cholesterol, and we make a few things. So we run through every little arrow is actually blue label. It represents an enzyme. And these, actually, the little arrows represent the enzymes, and the enzymes do little changes to the molecule. So we start with cholesterol, we do a bunch of changes, we end up with something called aldosterone, and aldosterone is required to raise blood pressure. And why would you want to do that? Well, when you stand up from a sitting position, you need more pressure to pump blood into your brain, and so you need to raise blood pressure, and one of the mechanisms to do that or to trigger that is this hormone aldosterone. We need cholesterol to make cortisol. Cortisol is a stress management tool. It helps modulate the immune system, and so it's important that way. We use it to make something called DHEA, which is a parent hormone for the other hormones down the road there. That gets converted to testosterone and the 3 versions of estrogen. So if you want to do any of the steroid hormones, you need to have the precursor, which is cholesterol. So important in the body. Cholesterol is also a precursor for vitamin D. So vitamin D is made by the body. We can also get it from diet, but we've inherently been doing it by making it in the body for millions of years. And the way it happens is we have cells in our skin. There's cholesterol in the membranes of those cells. When UVB light shines on it, so it has to be UVB, sunscreens block that, by the way. When the UVB shines on it, then what happens is that cholesterol gets modified, and then it gets absorbed over the next couple hours into the bloodstream. It travels to the liver activates it, travels to the kidneys, and the kidneys make it into a hormone form, the hormone form of vitamin D. Vitamin D is important for a lot of things. Building bones and maintaining bones. It is a potent anti-inflammatory in the brain. It helps mood in the brain. It inhibits the immune system, and it boosts the immune system. So it's a potent autoimmune suppressor. And vitamin D is one of the big deficiencies in North American society because we do not get enough sunlight. So we make our vitamin D from cholesterol, so that's one of the last of the important roles I'm going to talk about. Here's vitamin D. It's in the skin, starting as cholesterol. It goes through a bunch of enzyme transactions, I'm going to say, and ends up looking like that, and that is the hormone version. So we have this cholesterol, and cholesterol is we're going to call it a lipid, and the lipids are basically fats. So we have fatty acids, and we have something called phospholipids. Yes?
Sorry to interrupt. I just before we go too far, you're talking about the HDL, right?
No, I'm not talking about HDL. So the question is, am I talking about HDL? No, I'm talking about cholesterol. And we're going to talk about what cholesterol and HDL and all those guys are in a second.
So HDL really isn't cholesterol?
Just why don't you just hang on and see if I answer your question.
Okay, sorry. Yeah.
Okay. So, so fats and lipids and cholesterol are fat soluble. They do not like water. And the bloodstream is water-based. So you cannot ship cholesterol or fats around in the bloodstream as is. You have to package them up, and you package them up in something called lipoproteins. And lipoproteins are these. This is a ball, it's a sphere. These things are microscopic, but there they are. And the outside has this wrapper. These are phospholipids. It's, I'm going to say, a protein head with 2 fatty acids, and it makes a wrap around the outside. The protein likes water, whereas the fat doesn't. So proteins line up on the outside, and the fats line up on the inside. And inside the ball, we have triglycerides or fatty acids and cholesterol inside there. And so that is how we ship cholesterol around inside the bloodstream. There are a few different flavors of these lipoproteins. One of them is chylomicrons. So chylomicrons carry triglycerides, which are 3 fatty acids bound together, and they carry cholesterol, and they carry them to the body. I'm going to say "to" in brackets. So generally speaking, they bring cholesterol and fatty acids in. Chylomicrons are made by the lining of the intestines. So basically, the fats and cholesterol come in, they're packaged up into a ball inside an intestinal cell, and then they're put into the bloodstream and they're shipped around. And as they travel through the blood, the fatty acids are delivered to cells that need them. Fatty acids get burned as fuel. They play a lot of structural roles and other roles in the body. So the body is more than happy to take these fatty acids out, and they empty this chylomicron of the fatty acids until there's mostly just cholesterol left. And at that point, the liver will pick it up and take it apart and pull out the cholesterol and store that cholesterol for later use. So the next one is something called VLDL, and these are actually made by the liver. And what they do is they carry around cholesterol, which is, I'm going to call the orange stuff, and triglycerides, which is the fat, and they carry them around in the bloodstream, and they're basically delivering these two to the cells. So we're going to be delivering and dropping off fatty acids at cells, and as we drop off the fatty acids, this ball that's containing them gets smaller because the contents are less. Fatty acids going out, and the whole wrapper thing gets smaller. And when it gets most of the fatty acids are out of that VLDL, we rename it as an LDL. So it's the same particle. It was big, and now it's small, and you rename it. Actually, if you look at it this way, when it was big, it was full of marshmallow and marbles. Marbles would be the cholesterol. And as you empty out the marbles, empty out the marshmallows, you end up with just marbles. That's way more dense than just marshmallows and marbles. You get that picture? So what happens is the overall density gets greater. So it goes from very low density lipoprotein to just plain low density lipoprotein, but it's the same particle that left the liver. What ultimately happens is the LDL will then deliver cholesterol to cells that need it. Actually, the cells that need it actually gobble up. They take the whole LDL inside the cell, and they dismantle it, and they take the cholesterol out. The last one I'm going to talk about is HDL. Here you go. And HDL leaves the liver. It's made by the liver, but it leaves the liver empty. And as it travels around, it goes to cells that want to get rid of their cholesterol, and it picks it up. And actually, it takes this cholesterol and it delivers it back to the VLDL as well, and it delivers it to a few other places. So it's basically the distributor of cholesterol in the body or in the bloodstream, and it's a master regulator. So we call this one, or the medical guys call it the good one, because it picks up cholesterol and removes it from the body ultimately. Here's the thing, all of this is normal. I'll get you in a second. Every single one of these molecules has been in existence with humans for about 4 million years or more, and they are there and they're supposed to be there. So if all of them have been there since the beginning of time, which one's the bad one? None of them are bad. They just are. Who calls them bad? Pharmaceutical, doctors, medical institutions, because if you believe cholesterol is bad, then the one that's delivering cholesterol to cells will be bad. But I'm going to show you that, well, I already showed you the main roles of cholesterol. You can't live without them. You take cholesterol out, you're dead in a couple days. So whether you're delivering it to or from is irrelevant. Okay, can I have a question?
It's just a point of clarification. So the HDL, it recycles cholesterol? So it just so that I'm clear, I think I understood what you said, that the HDL takes cholesterol from the other cells and then recycles it and turns it back into the VLDL?
Kind of. Yeah. So does it recycle? It
recycles it also.
Look at it more like this. All right, look at it more like this. Have you guys ever seen two UPS trucks back to back in a parking lot? Anybody ever seen that?
Yes.
You will see that from time to time. So what's happening? Well, there's two trucks on the road. One of these guys picked up some parcels. The other guy's delivering parcels, but they said, hey, we got some parcels here that we don't need to send back to the big central building there. We can just drop them off in between. And so they're doing an out in the road transfer. That's what HDL does. It picks up some cholesterol from a client, and now it's going to deliver it back to the VLDL so that it can deliver it to somebody else. So we are constantly cycling and moving and transporting our pool of cholesterol around in the body. It's very efficient that way. I hope that answered your question.
So then the medical professionals, they're looking at the measurement of each of these components?
We'll get back to the medical side.
Okay.
Sorry. So the whole lipoprotein thing is actually very complex. I just talked about the main guys in the transportation of cholesterol and packaging and fatty acids. Here's the liver, here's the digestive tract, here's the chylomicrons, and you can see there's some transferring back and forth of TGs as triglycerides and cholesterol, CEs as cholesterol esters. So they're going back and forth. There is a lot of interaction going on, and it's obviously way complex. Way too complex, very complex. There we go. So the reality is cholesterol goes up. And so why is that? Because there is an association with, I'm going to say, elevated cholesterol. I keep doing these quote marks because I have to be clear that it's not cholesterol. So we do know that when the medical guys measure cholesterol and the levels are up, there is an increased risk of disease. So here's the thing, though. When we're talking about cholesterol, we're talking, let's put it this way. Cholesterol is to LDL as apple seeds are to apples. So if you looked at a bushel of apples, so here's cholesterol, here's LDL. If you looked at a bushel of apples, would you say, wow, there's a lot of seeds in that basket? You wouldn't. You'd say there's a lot of apples there. LDL is the thing that causes the problem, not cholesterol. The container is the problem, not the contents. They use the two words interchangeably, and I'll show you why later, but it's a misnomer, and it leads to a lot of damage and destruction to the human body and a lot of profit for pharmaceutical companies. So here we go. The goal, generally speaking, is, or generally we talk about high cholesterol, we're generally saying this person has too much LDL and not enough HDL, because we are supposed to have a nice ratio. If the ratio is nice, so the guy's delivering and the guy's kind of returning is in a good balance, then everything works nicely and we don't get disease. But when we get too much of this and too little of that, then we see some problems. So what causes this elevated LDL situation or elevated cholesterol? First of all, too many sugars and starches. So lots of sugar and starch. Why? Because sugar gets created into this molecule by many, many steps, and ultimately it ends up as cholesterol. Another way to look at this is there's an enzyme that builds cholesterol. It's called HMG-CoA reductase. There's actually many enzymes, but the rate-limiting one, the one that drives the actual rate that you build cholesterol, it's called HMG-CoA reductase. Insulin turns it on. When there's insulin, where does insulin come from? It's released in response to sugar and starches in the body. Sugar and starches increases insulin. Insulin says, make more cholesterol. So that's number one. Number two, excess damaged fatty acids. So when we eat trans fats and garbage fats from, say, plant-based oils that have been baked or fried, or you see them, corn oil and stuff in a clear bottle on the shelf at the supermarket, those are damaged fats. And too many of those increases the rate of cholesterol production. Here's a nice little study. It basically shows trans fats increases LDL, triglycerides, and insulin levels, and reduces beneficial high-density lipoproteins. So we know from the studies that too many of the bad fats increases the cholesterol, or the LDL part, and decreases the HDL. Low dietary fiber is another issue. Because we get rid of cholesterol, there's only one way cholesterol leaves the body, and that is through bile. And so we put it in bile, and if you do not have fiber, then you recycle your bile. You reabsorb it in the large intestine, or small intestine. So what percent of bile gets reabsorbed if you don't have enough fiber? 96% gets reabsorbed without fiber. So if you want to keep your cholesterol levels balanced, or keep the cholesterol balance in check, then fiber helps suck out that cholesterol. Increased need for membrane integrity. So there are a few reasons why. I talked to them at the beginning there. Toxins on the outside and dehydration are the two big ones. And so if we are exposed to environmental toxins like we are, and how many people drink 2 liters of water a day? Yeah, in this room, it's 50-50. Guess what it would be outside this room? I could tell you with 700 clients approximately in the last 10 years, it's about 20% of people actually drink enough water. So what's the response going to be? In some cases, it's going to be raise that cholesterol delivery so that we can put more cholesterol in the membranes. Chronic stress is a big one. Why? Because we make cortisol to manage stress, and cortisol is made from cholesterol. And so when people are under stress, we need to make more cortisol. We deliver more cholesterol to the adrenal glands and the brain and a few other places. And guess what happens? Doctor measures it on the way to be delivered and says it's high. Well, it's high in response to the stress. Low thyroid hormone. So thyroid deficiency or subclinical low thyroid is a hidden epidemic. Some sources say up to 70% of women who are over like 30 are walking around with subclinical low thyroid. And what low thyroid means is, ultimately it means the activity of thyroid hormone at the cells is low. But that comes from a bunch of other steps. So here's the thing, it boils down to thyroid hormone, which is T3. So T3 is tyrosine plus 3 iodines, and when those things are delivered to a cell, they dock and they go and they actually modify the writing of DNA. So hugely important. But thyroid hormone, when it gets to that enzyme, HMG-CoA reductase, it puts the brakes on that enzyme. So it limits cholesterol production. So when we have thyroid hormone, we put the brakes on that enzyme. Hang on a second. Thank you. Okay. When we don't have that enzyme, or when we don't have that hormone, it does not put the brakes on, and that enzyme goes rampant, and it just generates cholesterol and cholesterol and cholesterol and cholesterol. So low thyroid hormone is a big contributor to elevated cholesterol, or it can be. The last one we could talk about is menopause. And at menopause, women's ovaries stop making progesterone and estrogen. And so the global or the circulating amounts of those hormones drop, and the body likes to maintain, and so it's going to do some things to actually kick kick up that production during the first stages of menopause. And so what it does, it says, okay, so estrogen and progesterone are made of cholesterol. Let's push more cholesterol in the bloodstream. More will be picked up, and then we get those levels stabilized. So that's what happens. So cholesterol levels with some women can go up at the beginning of menopause and stay up there for a couple of years, actually all without any issue or any increased health effects that have been proven. So it's just another natural thing. So let's talk about plaque. So atherosclerosis and the plaque buildup. So we talked about cholesterol, we talked about these delivery molecules, and let's take a look at what actually happens for this atherosclerosis function here. And so it goes like this. The prevailing medical hypothesis is that cholesterol causes, and I use that word quite frequently, atherosclerosis. And here's a nice little diagram that shows a normal bloodstream. And then what happens is we get this plaque buildup, and you kind of see it's mostly uniform, drawn as cholesterol. And so cholesterol is this hard, waxy lipid that looks a lot like that. And so that's what they've drawn in this illustration. And so as this buildup happens, then we get a tighter and tighter space there, and we decrease the blood flow. So that actually happens, but the question is, what's this stuff? The other part that can happen is this little layer, it's actually only 1 cell thick. So that wrapper that protects the lining of the arteries is 1 cell thick. And when it gets full of, or when you pack underneath this cholesterol stuff, it gets very inflamed and delicate. And if it rips open, then you rapidly get a clot there, and it can block the blood flow. So that's the danger of it, and that's actually very real. So the story is that plaque is made of cholesterol. The question is that true? And here is what the actual composition of plaque is, based on a couple research papers or research studies where actually took some plaque and said, hey, what's it made of? Let's see. And so we've got fibrous protein, we got 16% lipid core. So what that lipid is the trans fats and the rancid fats. It's the fries and the potato chips, the oils that were used to make that stuff. The damaged fats are in there. There's calcium in there. I'm going to talk about calcium coming up. Inflammatory cells, there's these things called foam cells, which we're going to talk about, and then there's cholesterol. So there's other things that are, so less than cholesterol, we got muscle tissues, we got triglycerides in there, phospholipids, minerals, heavy metals, and cellular debris, but this is very small. And so the question is, can it be caused by cholesterol if it's so small? And we're going to see that it's not. So in order to understand how plaque is formed, you need to understand where it's formed. It's actually formed under the layer of skin that lines the arteries. There's a little space called the elastic membrane, and underneath that is muscle cells. And so it's in the elastic membrane. We can look at it this way. So if this is inside the artery, there's a layer of endothelial cells, so skin cells. There's an elastic membrane. This is actually what plaque kind of looks like. And then there's some smooth muscle. And so basically all the action happens inside the sandwich. So I'm going to take you through the key players in atherosclerosis now. So number 1, vitamin C deficiency, which is kind of surprising, but here we go. Some of the roles of vitamin C is the antioxidant, so protects cells from damage, protects things inside cells from damage. And it's also required to make collagen. Collagen is these fiber-like things that give elasticity and strength to tissues and membranes, and so you need vitamin C to do that. We're going to see where that shows up in a second. Vitamin C is depleted by free radicals, so environmental toxins and things like that, smoke and chemicals and heavy metals, but it's also depleted by bacterial infections. So the key, most important bacterial infection that's tied to atherosclerosis in medical research is dental infections. Ones that are inside the jaw, below the teeth, where the immune system can't get to it. And so it just goes there, and its toxic byproducts deplete vitamin C, but other antioxidants. Dental infections can deplete, from what I've seen by trying to replete people after, and some of the research, they can deplete 10 to 15, maybe even 20 grams of vitamin C a day. That's 20,000 milligrams of vitamin C a day for one infection. So you can very quickly deplete your body's supply of vitamin C, and that's a key player in atherosclerosis. So the next one is homocysteine. And homocysteine is a molecule that is actually resin in the body. It's made by the body from methionine. And the problem with homocysteine is it's damaging to the arteries. So here's the simplified methionine cycle and folate cycle. And I'm just going to show you a few. Oh, here we go. This is actually a really cool diagram because it shows how one or two nutrients are tied to a lot of things. Here's methionine. It makes something called SAMe. We use that to actually activate DNA and RNA, do protein and lipid transactions. And in the process of doing this work, we end up with something called homocysteine. So we take out these methyl groups, carbon and 3 hydrogens, and end up with homocysteine. Homocysteine is toxic, so we want to return it back to methionine, and so we do by running it this way. And what we do is we pick up, this is THF, is tetrahydrofolate, so folate from foods, and so we're going to stick that folate on, or we're going to stick on B12, there's another little diagram there, B12 onto it, and then we go back to methionine, everything's cool. The other thing we could do is we can stick choline, choline that comes from nuts and seeds and egg yolks, or trimethylglycine, which is better known as betaine. Anybody who takes stomach or acid digestive enzymes with hydrochloric acid is typically bound to betaine, and that molecule, those two molecules donate their methyl groups back to that homocysteine, and it goes back to methionine, and everything is normal. So that is kind of cool. So this has to work, this has to work. If we take a closer look, so we just do this cycling, we go from here to toxic homocysteine, we add these guys back, and everything's works fine. So the question is, how many people eat dark leafy greens on a regular basis out there? Not a lot. How many people get B12? And in order to have good B12, you have to have good stomach acid, you have to have good digestion. You can't have any inflammatory conditions in the digestive tract like colitis or Crohn's disease or inflammatory bowel or celiac, irritable bowel. Any of those will block the basically taken in B12. The choline and betaine, if you don't eat eggs, you're not going to get choline unless you're doing lots of legumes and soy in particular. So a lot of people are deficient in the nutrients that we need to actually convert homocysteine back from its toxic form back into its non-toxic form. One of the problems with homocysteine is it actually damages the cells that line the arteries, damages the brain too, and it damages the space between the cells, which is a nice segue into the next key player here, which is ground substance. Ground substance is the gel that is between the spaces in things. And so that would be like this. It's like caulking for cells. So the cells are stitched together, but we put the ground substance in, this thick gel stuff, to keep other things from leaking in. And so ground substance requires vitamin C to be made, to make the collagen part. If you don't have enough vitamin C, the ground substance dissolves away. Homocysteine also damages that. Next key player, number 4, is insulin. And insulin levels go up in response to glucose levels in the blood. Glucose levels in the blood go up in response to sugars and starches. So starches like white bread and potatoes and pasta and white rice, long chains of 3,000 or so glucose molecules linked together. When you cook that up, the molecules, the connections are kind of weak, and so when it gets in the digestive tract, it just falls apart, and suddenly we have 3,000 glucoses hitting the bloodstream at once. And so blood sugar goes up, and we make insulin because we do not want to have lots of glucose in the bloodstream. We want to put it away. And so what happens is, in response to insulin, we put glucose into the cells, we put glucose in the liver, and the liver converts it to glycogen, which is our short-term storage form. Liver also converts it into fat, and insulin tells fat cells to uptake the fat that was made by the liver. And anytime you eat anything with sugar, 10% of that sugar or that glucose immediately goes into the liver and is immediately converted to fat. So no matter what you eat, if you eat a piece of toast, 10% of that carbohydrate in that piece of toast will be converted to fat. Unless, of course, you're running a marathon and you burn it up immediately. Otherwise, it goes into fat storage. So these low-fat, high-sugar treats and things that we have out there, you're not eating the fat, you're making it yourself. So it's no better. Insulin also increases inflammation in the body, and inflammation is not good. Well, it can be. So here's what inflammation looks like. All red, swollen, and hot, and painful. That would be a toe. That's actually gout that's inflamed a toe. But in membranes, if you inflame those membranes, they start to misbehave. They become more delicate. They damage more easily. They oxidize more easily. So it's a big problem. Why do we have inflammation at all? Well, if you cut yourself, you want to seal off the area to keep the bad guys out, reduce the blood flow. You want to put some fibrin down so that you stop bleeding. You want to call the immune system in there to attack any bad guys that happen to get in. And you want to increase pain so you don't keep using that hand. And that's a normal physiological response and has a time and a place. Eventually, the inflammation goes down, the healing happens. In the arteries, when you have inflammation there and it's ongoing, it becomes a problem because you can't heal damaged arteries as long as there's inflammation. And so what was driving that inflammation? It was the insulin. There's another thing with insulin, and what it does is insulin empties out fatty acids from LDL, or VLDL and LDL. So we're going to come back to that shortly. But what it does is insulin's a signal to take those fatty acids out. Number 5, LDL and SDL, which stands for small dense lipoproteins. So here's our LDL. We apply insulin to it, fatty acids go out, it gets smaller. We keep doing this, more insulin, smaller and smaller and smaller, until we end up with this small dense LDL. You notice in these ones, there's still some yellow, which is the triglycerides or the fat. In this one, there's no triglycerides or fat. We've really emptied this thing out, and now it's really small. Now, there's a problem with small dense LDL in that the large fluffy LDL doesn't really easily get through the cells that line the arteries, but the small dense LDL does. And when it gets in there, we have some problems because it's not supposed to be there. Next key player in all this is free radicals. And what happens is free radicals are these toxins, and what they do is they damage cell membranes, or the cells, and they damage, or basically they oxidize the small dense LDL. So basically they steal electron from it, and now we have this oxidized small dense LDL, and the immune system, when it sees this, thinks it's a toxin. It thinks it's either a bad bacteria or something that needs to be disposed of, and so the immune system gets called into play when this guy is underneath that skin membrane and gets oxidized. Where do free radicals come from? Environmental toxins, the smoke, all the stuff that's in the air and the water, the things you bring into your house that have a smell to them. That stuff's toxic. I was driving on the highway and I was behind a car and I could smell the guy's air freshener in my car on the highway, and this guy is loading up on his environmental toxins. And another key free radical source is iron. So iron's one of these molecules that if you don't have enough, you die, and if you have too much, you die, because iron is required to run a whole bunch of functions, but in excess, iron is one of the most potent free radical generators in the body. It's a catalyst for making free radicals. And so excess iron in the bloodstream causes free radical damage as it floats through, and a few other things. Yes?
Does it matter how quickly iron comes into your bloodstream?
It doesn't matter how quickly. The only thing that matters is excess. So when, it's just the excess. It doesn't matter.
Because I know women often get iron shots.
Yep. So if they're in excess while they're putting it away, then it's going to be toxic. So yeah, so with the shots, so that may be a couple minutes, maybe a couple hours, or it may not be at all. Depends on the metabolism.
The reason why I'm asking is because so many women are iron deficient.
Yes.
Because they're iron deficient, they receive large quantities of iron all at once in
Yep.
order to try and stabilize their iron levels. And if it's a free radical source, getting that overload of iron without developing nutrients to do all the other functions, is that problematic?
That is problematic. So the question is, if you get people who are low iron and you give them high amounts in a short period of time, is that problematic? The answer is yes. We should not be getting iron in massive shots or massive doses in pills. You know, it causes constipation. Why? Because the body doesn't want to uptake it, that dose. So yeah, low-term, gradual increase of iron is the best way to go.
Generally, like if you're supplementing yourself, then you would run the risk. But in terms of if you're low iron,
Yeah.
they know how much you are low, and they'll generally give you a dose that tops you up, not just giving you a random amount for everyone. It's specific per person how much iron.
Are you saying, I think you're saying that when somebody's low, they go to a doctor and a doctor gives them an amount that's measured by how they're deficient?
If people do.
People do not.
There's different ways to go about not being iron deficient.
Yes, there is.
Yeah.
So-
So I'm just saying if you're supplementing yourself, you run that risk much more.
No, if you're supplementing yourself, you run the risk more. I would say no. If you're getting an iron shot, then, or you're getting prescription iron, then you're probably more likely to go and overdose than if you go and buy a supplement that's like 15 milligrams, the amount the body can absorb, and you do it as directed on the label. Now, the best way to get your iron levels up is to work with somebody who knows how to get iron levels up, like somebody who's a holistic nutritionist. And so you do it properly.
But what I was saying is when people are supplementing, they generally don't know how much they need.
Right.
Do you know what I mean? And they think that they're low iron, they're taking an iron pill, and they might now have too much iron.
Yeah, eventually they run that
speaking
dose.
to someone first
Yep.
to figure out, to actually get a test to figure out where your levels lie, then you supplement on that, not
Yeah.
to just assume that you're lowering something and start taking pills in
Right.
excess.
Actually, I'm going to cut this because this is not iron today. But here's the thing. The thing about iron is iron deficiency is about iron, it's about folic acid, or folate, B12, it's about protein, it's about a whole bunch of other things. So this whole discussion of iron is almost irresponsible, other than to say excess iron in the body is a potent free radical generator. So we're going to stop there just because we don't have all day, because I'm going to get cut off and at my end of time. So other key players are monocytes, macrophages, and foam cells, and these are immune cells. So what happens is we get these small dense LDLs in, they get oxidized, the body doesn't like them. We have these monocytes, so these are little gobbler cells that go around the bloodstream and they gobble up toxins in the bloodstream. They don't work in here, so what they do is they cross under that skin layer and they change their nature. Basically, they become stationary and they reach out and grab toxins and pull them in. So what they do is they grab up the small dense LDL and sequester it. Now, normally, macrophages gobble up stuff and destroy them and then just release the byproducts, but they have trouble with small dense LDL. So what they do is they accumulate it, and over time, this macrophage gets bigger and bigger and bigger, and then it changes its nature so that it can hold more, so to speak, and it becomes what's called a foam cell. And so the foam cells are there, and they're underneath that layer, and what they're doing is they're accumulating these small dense LDLs. And then what happens is these foam cells send out these chemical messengers that tell the smooth muscle that's underlying, so the bottom layer of the sandwich, causes these cells to migrate into the space under there as well. And why would we do that? Because we're trying to get anything we can in there to gobble up these toxic small dense LDLs that have been oxidized. And so the next player is calcium. And calcium is another one. We're not going to go on a 5-minute tangent here, but I'm going to tell you that calcium deficiency is deadly and calcium excess is deadly. Calcium causes cancer in excess. So we're going to see over the next 5-10 years, more than likely, the 1,000 milligram daily dose of calcium be downgraded to about 800 from all sources, including supplementation. So calcium causes overexcitability in cells, especially in brain cells. but also in plaque. The other thing is calcium, when it gets into muscle cells, makes it stiff. And that's a big problem, which is what the next piece is about, arterial flexibility. Now, when we look at the capillary level, when you move a red blood cell through a capillary, the capillary has to flex, and the red blood cell has to flex. And we can only fit one through at a time in the capillaries. And so we need a flexibility there. When it gets to the arteries flex, but for a different reason. They're under high pressure, and when the heart goes and pumps, we get a pulse of blood going through, and it has to expand to accommodate that. If it was rigid, then we would crack that artery. We get tiny micro cracks in it. And actually what happens is when we have calcium in excess, it starts to deposit when we start getting they call micro fissures, little cracks in the arteries, and it's in there as it's actually in response to the mechanism of trying to repair. So the calcium goes in, we got excess in there, we start to get more and more rigid. I remember a speaker at one of the Orthomolecular Medicine conferences talking about his first day, his first bypass surgery as an intern, and his mentor, or his doctor, said, okay, go do the incision in the artery leaving out of the heart. And so he hands him the scalpel, and he takes the scalpel, and he knows what it's like sticking it through, and so he takes the scalpel, and he goes and sticks it in, and the blade snaps. Why? Because the artery was solid calcium. And does a solid calcium, so a piece of stone, have any flexibility? No. And so we start to get damage there, and basically it grows and gets bigger and bigger because it influences the cells next to it. So basically what happens is if we don't have flexibility, we get more shear stress. If you want to know what shear stress is, you get a nice volunteer up here, and I take your arm and go, and you know, when you twist both ways and it really hurts, that's shear stress. And if you do that in an artery, you're causing damage and inflammation. So arterial flexibility is really important. So here's the question. Do doctors know this stuff? Because I've mentioned the whole cascade of all the things that are involved there. By the way, did I mention cholesterol at all? And any of the contributing factors? No, cholesterol was not one of them. So do doctors know this stuff? I get this asked quite often, so I build this right into my slides. I went to U of T and got the first year med school textbook called Lippincotts Illustrated Reviews Biochemistry. And lo and behold, here it is, first year med school. Here is the inside of the artery. Here's that elastic membrane. Here's the smooth muscle cells. Here is, we got these macrophages that have migrated in. They become foam cells. The yellow stuff is the oxidized LDL. There's even a little diagram here that says there's the LDL, and it becomes oxidized LDL. And what increases that? Superoxide, which is one of the things that's generated from iron, nitric oxide, hydrogen peroxide, and other oxidants, so free radicals. And so makes oxidized LDL. And what stops it? Vitamin E, ascorbic acid, beta carotene, and other antioxidants. So when's the last time somebody went to a conventional cardiologist and was handed a whole bunch of antioxidants to prevent all this stuff? I've only seen it once. Okay, so basically everything I just talked about is described there. Here is a image from an article published in JAMA, and basically shows the whole cascade here. Here is the LDL that gets oxidized. Here's the monocytes coming in. Here's the foam cells. Here's basically what happens is the calcium also builds a cap, helps build a cap on the surface that prevents everything from escaping, so that's that there. We get the inflammation here because we have this insulin being pro-inflammatory and all the damage going on, and then we get the rupture, and here's the thrombus or the clot that could later go and block an artery downstream. So that is, it's showed by the medical system, so they know it. So the real risk factors for cardiovascular disease are LDL excess and HDL low, high sugars and starches, damaged fatty acids, nutrient deficiencies like antioxidants, the methyl donators for getting homocysteine back to methionine, low fiber, too much or too many free radical exposures without antioxidants, not getting enough exercise, smoking because of the toxins, type A personality because of the increased stress and then increased cortisol, therefore increased cholesterol production. Chronic infections because they deplete vitamin C. The HDL to LDL ratio is important, so it's a risk factor. HDL to LDL ratio is influenced by mostly nutritional things, nutrient deficiencies. So that's a big one there. Serum triglycerides, insulin resistance, metabolic syndrome, so too much sugar and not having the body respond to it properly. Systemic inflammation through the entire body, elevated homocysteine, elevated fibrinogen, which is the first thing that goes down to block damage. And then genetics, which is last on the list and accounts to less than 5% of all issues that are going on. And most of the time, genetics, to be an influence, requires some kind of environmental factor as well. So that's it. So there's no cholesterol on that list. So why are we looking at reducing this cholesterol? And so we're going to talk about addressing it. We're going to look at the medical system approach. And so here's the things that the medical system uses. They use statins. So statin medications block that HMG-CoA reductase enzyme, and that lowers cholesterol production. They block cholesterol uptake inhibitors or they block cholesterol uptake so you can't absorb it from your food. By the way, if you, about 70% of cholesterol is made by the body and 30% comes from food. If you stop the food supply and you still need cholesterol, the body will ramp up to 100%, and then vice versa. If you have more in your diet, the body will ramp down. So if you can block the production and block the uptake, then you can influence that number, and we're going to see that might not be a good idea. Fibrates decrease fibrin, so decrease clotting, and low-dose aspirin makes the blood thinner, but there's issues with it. From the diet, I'm going to say the diet is I'm being recorded. It's a not wholehearted way of doing it. The medical system likes to say, you want to try diet, go ahead. And when it fails, come back for the meds. I've seen that so many times. But they'll typically say low cholesterol diet, and the research shows low cholesterol diets do not have an impact on life expectancy from cardiovascular disease. And typically a low-fat diet as well, and same thing for the research. So why the medical system emphasis on cholesterol? And it boils down to, I'm going to be kind here because there's a lot of stuff I really don't want to say. I don't want to go really political, but if we're going to assume that they're making a mistake, then the mistake is correlation and not causation. So it goes like this: National Institute of Health. Why is cholesterol important? The higher your cholesterol, the greater your risk for cardiovascular disease. And that's actually true. Higher cholesterol levels, the greater your risk of cardiovascular disease. But did this cause this? And the answer is quite simple. It's the things that cause this also cause that. These cause atherosclerosis. Cholesterol does not. So that's called correlation. When you say this causes this, because we see the two together, it's like every time there's a house fire, what do you see on the highway? Fire trucks. And so the more house fires, the more fire trucks. Correlation would be, every time I see a fire truck, there's a house fire, therefore fire trucks cause house fires. And that's causation, or correlation versus causation. This is just for fun, showing correlation of things that are absolutely very tightly correlated. That number, correlation, means it's a very strong correlation and would also imply causation. But if you see this graph, the two of them go together, and basically it implies that margarine causes divorces. This one, consumption of cheese, a number of people who died by being tangled in their bed sheets, and you'll see this is a very high correlation as well, but it's not causation. So if the correlation hypothesis is, well, it has been disproved over and over and over again. There's hundreds of studies that show that it's not, cholesterol does not cause. Why are we still talking about it? And it really boils down to this: follow the money. And so here we go. This is National Institute of Health again. LDL, bad cholesterol, is the main source of buildup and blockage in the arteries. Did we see that when I went through the causes? We didn't see it at all, right? We didn't see cholesterol or LDL. We actually did see LDL is the main cause. Right, so that is actually true. So it's the main source of the buildup, but is cholesterol the part of the buildup? No. HDL keeps cholesterol from building up in the arteries. Does it? That's not actually true. It keeps LDL from getting incorporated. So cholesterol lowering is important for everyone. And here's where it starts to get a little crazy. Younger, middle-aged, older adults, men and women, and people with or without heart disease. So what they are saying is people are getting heart disease because of a deficiency of something that's lowering cholesterol meds. Something that has been in the body since the beginning of time is now, it's important to get it down. And why would you want to do that? Well, here's a nice class action lawsuit against Pfizer and against an NIH. It said Pfizer makes Lipitor, the biggest selling statin drug in the world. And these guys were populating the institution that educates doctors on how much cholesterol level or how much cholesterol we need and how dangerous it is. So the guys who make the drug are the ones who staff the institute that tells everybody what's safe. That's called conflict of interest, in case you didn't know. But is it true? So does lowering cholesterol at least reduce cardiovascular disease or deaths? And so it goes, here's a study in JAMA, there is no increased overall mortality with either high or low serum cholesterol levels. So it doesn't matter, higher or lower, there's no mortality difference. And for every 1% drop in cholesterol, there's 11% increase in all-cause mortality. The more you reduce the cholesterol, the more people died. From all causes, not cardiovascular disease, but all causes. Here's a nice study in the European Heart Journal, 1997, low total cholesterol associated with high total mortality in patients with coronary heart disease. There's the stats. There's basically the lower you take cholesterol down, the faster or the more people die. Here's a nice study in Journal Clinical Psychiatry, serum cholesterol levels and suicidal tendencies. Patients who attempted suicide had significantly lower cholesterol than non-suicidal patients. Was it something I said? Okay, so let's talk about the statin medications. Why are we not seeing benefits and why are we in fact seeing problems with the statins? Well, here's what they do. They block that enzyme, and so we don't make cholesterol, but we also don't make something called CoQ10 or coenzyme Q10. Coenzyme Q10 is required to prevent free radical damage inside mitochondria when they generate energy. If you damage your mitochondria, they don't make as much energy. If your cell doesn't have as much energy, it doesn't behave properly and it starts to degrade and ultimately will die if it goes on too long. And so this is very protective. CoQ10 is very important for brain health as well. And so what we see with statins is as you affect cholesterol levels, you affect the brain. The other thing about statins is they actually have an anti-inflammatory action. And so the benefits may be coming solely or primarily from the anti-inflammatory action instead of the cholesterol-lowering action. And if that's the case, there's way better anti-inflammatories than statins, and there are a lot of nutrients that work better than the meds. So statins deplete these: beta-carotene, CoQ10, calcium, folate, iron, magnesium, phosphorus, vitamin A. Oh, vitamin A is so important, it's there twice. B12, vitamin D, vitamin E, and vitamin K. So they're not benign. They deplete nutrients from the body every time you take them. So it's a big problem. So here is what's called the number needed to treat. So for every med on the market, you can look up the NNT, or number needed to treat. And what it tells you is how many people have to take or be on that med before one person sees benefit from it. And so this is the one for statins with people who have heart disease. And I'm going to basically simplify this here, take those statistics. So for every 83 people taking the statins, one life is saved. For every 39 people taking it, so every day for years and years, for 5 years actually, it prevented one non-fatal heart attack. And for every 125 people, it prevented one stroke. However, for every people taking it, one person got diabetes, And for every 10 people taking it, one person got muscle damage, something called rhabdomyolysis. So there's lots of references for this. It's not just made up. Here's when statins are recommended for people who don't have cardiovascular disease. No lives were saved. For every 104 people, one heart attack prevented. Every 154, one stroke prevented. For every 50 people, one got diabetes, and 10 people got muscle damage. So when you're weighing out the risk, you have to say, is it really worth doing this? Are we going to see benefit versus the risk of seeing some damage? Here's a nice little Health Canada advisory. Went out to all doctors way back when in 2005, and it basically said, you have to watch it with the statin meds because they cause rhabdomyolysis or serious muscle damage. And yeah, we'll leave it at that. So doctors do know about this, and they should be doing testing, but it's infrequently done from what I've seen. Statins modulate the immune system, so they suppress the immune system, especially the T helper cells. So then we start to see a risk of cancer and other health issues like that. This one, effects of magnitude of lowering risk of elevated liver enzymes, rhabdomyolysis, and cancer, basically said people who take statin drugs to lower cholesterol as much as possible have a higher risk of cancer and increased risk of Parkinson's disease and liver damage. 121 healthy young women with lower cholesterol levels, more depression, more anxiety. And this is a nice little paper written in British Medical Journal, and it says, focusing on elevated blood cholesterol concentration as the exclusive cause of coronary heart disease is unquestionably the worst medical error of our time. And he said, after reviewing all the scientific evidence, I draw just one conclusion: never prescribe a statin drug for a loved one. So, why would we do this? Lots of money. This is in the Telegraph. Statin drugs cause brain dysfunction, plus multi-billion-dollar profits for Big Pharma. And statins are the most profitable medications in the history of Big Pharma. And basically the recommendations is that all men should be on them, and 62% of women over age 70 should be on them. And even if their blood's normal, we can see Lipitor made $13 billion on that one drug. They might have some vested interest in keeping people believing that cholesterol is the cause of atherosclerosis. So we don't buy that. I mean, when we look at things that don't work, from the holistic side, we say let's work with the body and do things that it likes. So here we go. What works? A holistic approach for getting atherosclerosis plaques down, because you can actually do that, and addressing the LDL to HDL levels. Low sugar, by the way, I got a handout, so everything I'm showing you now is on that. Low sugar and starch diet. You want to keep that insulin down. High nutrient duet, that should be diet. It's always one. Okay, yes. So that would be vitamins and minerals. Supplemental nutrients, so going over and above what you need just to maintain. There's many botanicals out there, certain things like hawthorn and things like that that actually help cardiovascular function and things like that. Exercise and stress reduction are both important. Things we can do with dietary whole-based, whole food, or plant-based whole food diets, especially the Mediterranean diet. So plant-based means mostly plants. It doesn't mean no protein, no animal foods, or doesn't mean vegan. It means whatever you're doing, mostly plants, and then other stuff. So the Mediterranean diet is a good example of a whole food plant-based diet. Lots of nuts and seeds, a little bit of grains, small amounts of meat, fish, cheese, lots of fruit, lots of veggies, and lots of good oils, olive oils and walnut oils and things like that. So here's a study that showed Mediterranean diet supplements walnuts, olive oil resulted in 30% reduction in major cardiovascular events. So basically what we're seeing is if you give people this diet, their likelihood of dying from cardiovascular disease or having a stroke or things like that goes down by 30%. It's measurable. Here's a nice little slide from last weekend's Orthomolecular Medicine conference. A nice doctor from the UK called Benjamin Brown basically pulled this together, and basically it said when you're looking at preventing Statins are effective about 1% of the time, but the Mediterranean diet's effective 30%. And if you're looking at a dressing, statins work about 18%, and Mediterranean's diet, 76% of the time, or 70% increase in efficacy comes from food. Food is clearly the better, more effective way to go. Low age cooking. Age stands for advanced glycation end products. And these are little molecules that are toxic to arteries. And they are generated anytime you take protein and starch to high temperatures, so grilling or baking. So the outside part of the loaf of bread, which we used to fight over when we were kids, has the highest age content. And so grilling foods as well. The way to keep the age content down is to cook it in moist, so water or moisture keeps the content down, high temperature dry takes it up. So the more you do grilling and high temperature bacon, the more of that you're going to get, the more trouble. So if you keep it low, the less trouble you get. So a single real-life high-age meal introduces profound impairment of both macro and microvascular function. So 36 and 67% decrease in function of the arteries and the capillaries from a single meal that had high ages in it. Lower acid-forming foods is beneficial. So acid-forming foods are like the meat and dairy. So if you go higher on the fruit, I should say higher in the veggies and fruit and lower on the meat, dairy, and grains, you're going to be more on the alkaline forming instead of the acid forming. Short-term 10-day intervention, a highly alkaline diet resulted in improvements in vascular reactivity and lipid profiles, so LDL to HDL. So we see just shifting over the pH of the food has a difference. Calorie restriction, which means less of the high-calorie foods like grains and meats and dairy, and more of the veggies and fruit. You're seeing a trend here. The less calories, the less plaque formation we had. And antioxidant polyphenol-rich foods. So antioxidants will be the vitamins and minerals, so things that are high in vitamin C, like citrus. Anything that's got colors will have polyphenols typically, so the reds and the purples and the blues, like blueberries, grapes, and those guys, all of them help provide protection against cardiovascular disease and HDL, LDL. And then probiotics, having a good digestive tract works on many, many ways. It modifies gene transcription, and basically it keeps down the amount of toxic byproducts that are getting in the bloodstream and causing the cells to want more cholesterol built in them. There's a few key nutrients. I'm going to wrap up with this little list here. Vitamin C, alpha-lipoic acid, if you're going therapeutically. I tend to use doses, and you guys don't do this unless you know what you're doing, but also ramp up. I use doses up to 20 grams of vitamin C a day with people who are very high risk or have plaque that we want to take down. Most people I run at 6 grams a day for 2 months to normalize their vitamin C, because most people are deficient. Alpha-lipoic acid is a nice little molecule that replenishes vitamin C, among other things. Vitamin E, or mixed tocopherol, or as a form of mixed tocopherol, so alpha and the other forms. Vitamin C is the main antioxidant in fluids, the water-based, and vitamin E is the main antioxidant in membranes, so in the fat-based stuff. So we get protection from both there. The methyl donators to turn homocysteine back into methionine, so folic acid. Actually, that should say folate. B12 and choline. Folic acid is a synthetic form, and is not beneficial, really. Niacin and niacinamide have been shown to decrease LDL and increase HDL a lot of times as effectively as the medications. So niacin causes that skin flushing, which is basically opening up the arteries and capillaries, more of the capillaries, to allow more blood flow. And more blood flow brings more nutrients, and so it's highly beneficial. EFAs, especially LA and ALA, which is omega-6 from nuts and seeds, and ALA is the omega-3 from flax oil and walnut and chia and that kind of stuff. Also, EPA is shown to be beneficial, the stuff from fish oils. to a degree. Going too high on EPA has not been shown to be beneficial, so you actually need the whole spectrum. Plant-based oils that are good and clean, and perhaps some fish oils. Garlic is shown beneficial. It actually lowers LDL and has some evidence of raising HDL. It kills bad bacteria, which helps in the gut. So there's lots of reasons for that. And the proanthocyanidins, so those colored components of the things like grape skin, pine seeds, and things like that, all shown to help get the cholesterol or the LDL, HDL levels and the plaque buildup down. And that is all I have to say about that. And so my website's healthybyknowing.com. It's also on the handout. And thank you for your attention. Thanks.